Without further ado, I do want to welcome the CEO of the Nevada Hospital Association, Mr. Pat Kelly, that joins us today. You can give him a round of applause and a warm welcome.
Thank you, Diego. Absolutely. Well, good morning, everyone. When I was getting ready for this upcoming week, I was talking to my wife, and I told her that I was going to see the state of Nevada because I was going to spend the first couple days of the week in Elko, and then I was going to head to Las Vegas. And she said, well, what are you going to be doing in Las Vegas? I said, well, one of the things I'm going to do is go to this breakfast event called Game of Thrones. And she said, man, that's a really weird name. And I said, well, apparently they have a speaker, and then people ask and really pepper them with questions. It's really difficult. And she goes, who would be dumb enough to volunteer to do that? So I've not impressed my wife this week, but if I come back alive to Reno, I think that she'll be very happy and hopefully impressed. What I want to do is just talk about a few issues, and I know I've been told you guys have tons of questions, and I'm looking forward to that. And I've got so many experts just at this table, and I know in other places that we'll be able to answer those for you. But I want to talk first about hospitals, and then I'm going to talk about workforce, and then a little bit about insurance. And what I thought I would do is after each segment, just stop, pause for a minute or two, and let you ask questions while we're on that topic, and then we'll move on to other things. So with respect to hospitals, the very basics are we have about 68 hospitals in the state, and that's everything from the general acute care hospitals, critical access hospitals, rehab, psych, and the federal hospitals that are in the state. And we have 3 federal hospitals. We have a VA in the north, VA in the south, and then Nellis Air Force Base has a hospital. They are not a member of our organization, but pretty much all the other hospitals are. So we do represent a lot of people, and our mission is really to bring all the hospitals together so that we can have a unified voice. Because as you know, there's several topics going on in this community where there's a split of opinion. And it's just important to have a forum in which we can bring people together to discuss these issues and try to work them out. So that's one of our goals. Now, if you think back, I know a lot of people are like so over the pandemic and COVID and everything, but hospitals, many of them are still just getting over the pandemic. I mean, it really had a profound impact because for a couple years, everything changed. There was no normal. And so they're trying to get back to the point of finding a normal. And the finances of hospitals have always been challenged during that time period. And it was really weird because you couldn't have a lot of the elective surgeries and different things that occurred, and that was financially damaging to the hospitals. But on the other side, you had the federal government pumping some money in. So, you know, you just really, when we came out of it, you didn't know where you were going to be and what the future was going to look like. So just a couple years ago, we had just under half of the hospitals in the state that had an operating margin of 1% or less. So why is that significant? Most experts will agree that you have to have at least a 3% operating margin to survive. So we had all these hospitals that were in the negative or had just 1% operating margin. And so that's a very scary thing when you're sitting there looking at half the hospitals being in that position. But so how do we get into that position? And it has so much to do with the case mix that hospitals see. So to give you an idea, 40% of our patients are Medicare, 25% are Medicaid, and then we have about 5% uninsured. So if you look at Medicare, they pay about 87% of the cost of hospital care. So I'm not talking about the charges. What we charge is the actual cost of providing the care. They pay about 87% of it. So you're losing 13% on every Medicare patient. Then you have Medicaid, who they pay about 53% of of the cost of care. So that's a big loss for hospitals. And then the uninsured basically come in, the 5%, they pretty much don't pay anything. I mean, they make a few payments, but you can pretty much write that off. So when you look at it, we have 75% of our patients who do not pay the actual cost of the care we provide. I mean, that's huge. How many of you in your businesses would survive if 87% of your customers or clients didn't pay the actual cost that you incurred in providing the service or product to them? You wouldn't last long. Now, what happens in the hospital area is the cost is shifted to the commercial group. And you've all heard of cost shifting. And that's what happens. But that's why we have a big cost shift in this state, is because we have a lot of payers who do not pay enough to cover the cost of care. So we've been struggling. To give you an idea on Medicaid, in the last 22 years, the base rate for Medicaid has increased to hospitals 5%. Not 5% each year, 5% over 22 years. I mean, that's staggering. Our costs during that time period increased 71%. So you can see how over the years this gap just keeps getting larger, and why we have this the cost shift and just hospitals that are really struggling financially. So finally, the hospitals got together and said, you know what, we do have to address this situation because we have a lot of our colleagues who are struggling. So we approved the Medicaid, private Medicaid provider fee program. And this is a program by which a healthcare provider taxes themselves, and then the state takes that money, sends it to the feds, to Medicaid, and it gets matched, and it comes back at a larger amount, and then that money is distributed. And you think about it, that's to me one of the craziest schemes in the world, but everybody does it. So what we're going to do is this year, we're going to pay $400 million in taxes, the hospitals, and we're hoping to get a net benefit back of $830 million. So, you know, it's going to have a really profound impact on the finances of hospitals in the state. But it doesn't cover everything. It's still, you know, it basically takes Medicaid up to Medicare rates, some getting close to average commercial rate, but, you know, we still aren't, you know, 100% whole. But to give you an idea, we provide about $1.2 billion in unreimbursed care a year. So that $830 million is going to help offset that, but there's still a big gap that exists. But I'm not here to complain, because we are thrilled to get $830 million and get this program up and running, because it is going to have a big impact. And we're already seeing where this money is having a greater impact on access to care for Medicaid patients. Because frankly, there's some specialty hospitals that just couldn't afford to take Medicaid patients. They're not big enough to spread the cost over, so they were limiting the Medicaid patients they were taking. Now we're seeing that they're taking more of those patients. And so that's a real positive. And that was part of the program. It wasn't just to shore up hospitals, but it was to increase access for Medicaid patients. So that's a real positive that we've got going on. So I'm going to just pause there and let you ask some questions about hospitals if you want. If not, I'll move on to the next topic. Yes, sir.
At $800 million, whoever came up with that plan was brilliant, so good job on that. The second one, if you go to the state of Nevada website on hospitals and all their cost, actually the 4 hospitals down here, the 4 systems down here, even UMC, St. Rose, Valley, and HCA, all have a pretty decent operating margin, and I just calculated before the home office cost, and it's well above 10%. But those are the state numbers, so they're just a little,
right.
I just have a little different perspective, but the fact you guys did a great job on the provider tax, excellent job. It was needed, absolutely.
I appreciate that. You do have hospitals that do well in the state. Yeah. You have others that,
rural hospitals have a tough time.
Yeah, but there are actually some urban hospitals. If you go and look at like the psychiatric hospitals, they really struggle. My gosh.
I'm just talking med surg, yeah.
Okay, yeah. Yes, sir, Jerry.
How does this compare to other states? How does Nevada compare to other states for hospital costs and margins?
Well, Forbes just put out a ranking of the states, and actually Nevada comes out at like number 6 and lowest in cost in the country. So, you know, I think that's something we can be very proud of. But in terms of the
survivability or sustainability of hospitals in Nevada compared to other states?
Oh, I think with this 800 million, it's going to be totally different. Before, the stats were not good, you know. But most of the other states in the country have this program already, and some have had it for decades.
Yes.
You know.
That was going to be my question, because I came from other states and they've had this for 20 years. So that, like, you know, we don't take advantage of the full amount of federal dollars with the matching, because we don't want to pay T-word, you know, taxes. But sometimes it's a wise move to think about doing that if it's going to come back and get the right thing going on. But, you know, my question is, okay, it doesn't meet your costs, but what are the costs? And can you work on the cost side of the equation as well? Can we help in terms of the community keeping people less, to come into the hospital less? Lower the amount of visits you have to make? Like, you know, this is not you're giving the picture of the hospital view, but what's the bigger picture view from your perspective, so that we can lower the cost of healthcare? Obviously, there's a massive amount of waste in healthcare in the country. It's well established. And the only way we're going to really attack that giant elephant in the room is to greatly lower costs. A little bit, a lot.
Mm-hmm.
Think about 20-30% reduction in your costs to really make this work. What's the approach there? What's the thinking there along those lines?
You know, we have some very high costs in Nevada. I mean, if you just look at the labor costs alone, it's huge. I mean, our average RNs are making about $100,000 a year now. Now, how does that compare to the rest of the country? That puts us like at number 6 in the nation for the highest paid nurses based when you adjust for the cost of living. So, you know, like Hawaii, I always talk to my colleague in Hawaii, they're like the highest payers in the country, but when you adjust for cost of living, they're in the lowest group because it's just so darn expensive. And it's expensive here to live in the urban areas. So, you know, that puts us up there. So that's a high cost. And when you look at it, we're like 30% of our costs are labor. So that becomes a big issue. We're now seeing, you know, the physicians are leaving private practice and they want to be hired by somebody. And they want income guarantees and different things. And that's expensive. But if you know, I've had legislators say, well, you know, we shouldn't have to pay all that. I said, well, you know, we don't get to buy Nevada prices all over the country. We have to pay what the rest of the country. And when you go look at the drug costs and different things like that, it's going up so substantially that, you know, we're just a pass-through at that point for things like that. So there's a lot of different areas that we have to tackle on that to get there. But yeah, I mean, I think people are going to be looking at it. I think there's just such a greater emphasis. And but I'll go back to one other thing, and that is primary care. You know, if you want to address it as a community, you can't have everybody on Medicaid using the emergency room for primary care. And that's what's happening to a great extent. It's just extremely expensive. And it also just clogs up the emergency rooms. You know, there's a lot of discussion about freestanding emergency departments. We've got to take the pressure off of these emergency rooms that are there, because there are times where if you really are sick and you come in, those emergency rooms are packed. And so they do take some of the pressure off of those emergency rooms. But, you know, I would say that one of the biggest problems in Nevada is that we don't address the basics. And I'm going to talk about the provider shortages here in a minute. And that is, if people can't get access to the basic healthcare services, you can bet at some time they're going to come into the hospital for major acute care problems. And so, you know, we just have to get there. And I'll go through, when I show you those statistics, I think you're going to be surprised at how poor we are in terms of access to care and healthcare providers. Yes, sir.
You mentioned about plugging of emergency rooms. Once upon a time, Governor Sandoval created an hearing committee to address that, and they found out that there's a lot of mental health illness that plugs it. And because of that, what are we doing to address the issue? Back in 2014, we suggested that there is a solution, because those people plugs the emergency room are chronic.
Yes.
They go back there. you know, how many times in 1 year. So either they go back there in the emergency rooms or they go to jail and stay there for a couple of days. That costs the state about $150 to $210 million. And yet there is a solution. One of the solutions that was suggested was those people who's got mental illness needs to have a housing, like a group home, a care home, that would provide them with medication management. Because once they have that medication management, at least they will be off the streets, right? Second, they will be housed, they'll have medication management, they will be better because of that medication management. When they become better, it's less for them to go back to the emergency rooms. But that has been on the table for a long time. Nobody is addressing that. Right now, we also have a group home shortage. I did a comparative study, Washington State, Oregon, California, NorCal and SoCal, Hawaii, and Arizona. We are competing as a retirement capital with Florida and Arizona. And yet, if you're going to look at the data, the number of facilities, group home, who could accommodate all those people with mental illness actually decreased. We used to have 88 facilities. Do you guys know how many facilities we have now? Less than 8. Because like what you said, there's no increase in their payments. They're still being paid the same amount since 2004. We're already 2024. And our population has doubled, tripled, and yet the number of facilities that can provide that protective supervision where hospitals can discharge them safely remains the same number-wise since 2000. And just,
No, you're absolutely right. Behavioral health is just such a lack of healthcare professionals, and reimbursement is a huge issue in it. Now, I do think that there's some bright spots on the horizon. So people always ask me, why didn't you guys do the Medicaid provider fee program years ago? Well, I wasn't here at the time, but what I understand is people were worried that money would be, the hospitals would be taxed and it would just be spent somewhere else. So, okay, so maybe that's paranoia, but what was the first thing that happened when we got the Medicaid provider fee program? The state took 15% off the top. So it's not paranoia when it really does happen. Now, that wasn't totally devastating, but the good thing is that 15% is going to go to administrative expenses to run this program, which aren't huge, but the rest is going to go to behavioral health. So particularly services for children. But you're right, I mentioned a minute ago, our psych hospitals have been really struggling because their reimbursement is not going up, their expenses are going up. The other thing that's happening is we're getting backed up in hospitals because we can't discharge people who are medically cleared to be discharged out because we've got a situation where we can't move the behavioral health patients out. We can't move older geriatric patients out because the skilled nursing facilities don't have enough staff. We have the beds in the community, but they can't get the nurses to staff those beds. And so, this whole thing gets clogged up. And that's why, I'm going to move on now to the shortage of personnel and address that. Go ahead.
You're already going to address it. I was just going to ask you, how many nurses are we short in the state, do you think? I'm sure you'll talk to me.
Yeah, I am. I'll start with nurses. I was going to start with doctors, but I'll start with nurses. So every year we've been taking a poll of our hospitals and asking them, how many open RN positions do you have? Well, during COVID and everything, it was just but last year in January, it was over 1,000 open RN positions. So we're ready to hire 1,000 nurses if you give them to us. But you can't get them. I would challenge you, how many of you know a nurse who's unemployed and can't find a job? They don't exist. And as a hospitals, we're kind of lucky because we're kind of a little bit at the top of the food chain. But when you get down to the nursing homes and others, man, they are really struggling. And that's a huge problem. We've got to address this nursing shortage because it's not going to get better. As a matter of fact, there's a projection that by 2030, Nevada will be among the top 5 states in the country with the most pronounced nursing shortage. Well, that is not going to help anything. And to me, that's one of the areas where we could really make some progress. I'll show you something that I think that's kind of interesting. There's a new college that opened up in this community. It was called Galen College, and you probably have seen the ads for it around town. And HCA went years ago and bought a college in Kentucky, and it had a nursing program. And they have built that nursing program up all across the country. And it's amazing what they're doing. I was listening to a presentation the other day, and their average age of their student is 33 years old. So they are going for the non-traditional student, people who don't really want to go back to the university to get their degree. They're more comfortable in this environment, and they help with the cost of the education, but you agree to work at their facility where you buy your contract out at a certain point. So I only say that I have been running around complaining about the public higher education not doing anything and expanding fast enough their programs. And people say, well, what are you doing? Okay, well, that's one of the things that we're doing. We're trying to get that going. And I think that's going to have an impact. Is it going to save the whole thing? No. But we're going to have to start coming up with some creative solutions to address this issue. Last year, we went to the legislature, or last session, and got $20 million for the nursing programs to do something. And I still don't know exactly what they did with that $20 million. I'm not seeing a lot more nurses graduate, but that's what we really need. Yes, sir.
Yeah, just to share, another issue is that we have the fastest growing number of APRNs. So they're leaving their nursing profession, they become NPs, and they do their own practices. Before we have the Philippine Nurses Association, that's just it. Last Saturday, they celebrated the 2nd anniversary of the NP organization. So, and there's hundreds of them. So, it may be hundreds, but if you're going to, look at how many nurses now transition to NPs, that's a big loss. You have 200, 300s. Now they have practices wound care, they have psych, they're all over the place. So I don't know if that's...
Well, where we feel the pain is that experienced nurses are leaving the bedside and they're going on to this. And it's great, I'm not going to hold anybody back or complain about somebody wanting to further their education and do things, but it does cause a loss within healthcare facilities, Yes, sir. No. It's interesting. We've talked about that a lot. And what happens is nursing, for some reason, is not a profession where people go and look at the highest paid areas around the country. They typically move when a spouse moves, and then they'll go. But, no, by paying more, we don't seem to attract more people in. Because, like I said, we're number 6 in the country. You'd think that people on the East Coast would be looking at this and just coming and saying, gosh, I can double, triple what I make. So, did you have a question? Oh, okay. Yes, sir.
Do you know, with all the different nursing schools that we have in the state, what the max capacity at one time would be? Like, how long would it take us to fill that delta? And especially when you talk about some of the intrusion APRNs, do we know what the capacity is in the state for the schools?
Yeah, I have that in the thing. I mean, it's a couple thousand, but the problem is when, like UNR and UNLV, there are a lot of out-of-state students who come in. And so we educate them, but the plan is they're going back home to wherever it is. So we lose them immediately. The other thing is we're going to have a huge retirement of nurses in the next few years. We've got just a high percentage of our nurses are 55 and older. And the assumption is that they're going to retire likely in the next 10 years. And I'm not sure we're going to be able to replace them. Plus, they're the most experienced nurses as well. So that causes another challenge for us. So, we just have to get together. Now, one of the good things that COVID brought was that because we were having such a hard time nurses and we were bringing all these traveling nurses in, we had to learn to staff in a little bit different manner. So there are different care teams that have been developed in hospitals that might involve EMTs. I mean, we're using LPNs again. You know, for a while it was like, oh, you don't hire an LPN in a hospital. That's just not acceptable. That all have to be RNs. But we have to. So we're putting together different teams with certified nursing assistants, everybody. So I think that has caused a little bit of creativity. But we would like to have the nurses. You know, there's no substitution for that experience and knowledge. Yes.
When you were competing with other states to try to bring travel nurses into the state here, because other states would have been, especially during COVID, did you find that the price of the amount that you paid them was afforded to bring that? They were more nurses would come and they were paid more or offered more?
So basically, everybody was paying very similar rates all across the country for travelers. So if you needed an OBGYN nurse and it was, you know, X number of dollars an hour, you were paying that all over the country. Everybody was pretty much paying the same rate. But yeah, if it was a few dollars more, could you get them? You could, but it was still high.
Has the hospital association done surveys on the traveling nurses who came to the state and worked here to find out what it was that Bill convinced them to stay? Because sometimes we hear stories about, you know, they were horrified with the experiences that they had when they came to work in hospitals in Nevada as compared to other states. But I don't see any data that, you know, somebody's collated this or studied this in an accurate way, or maybe I'm just hearing, you know, one-off stories. But I did hear it frequently, and so I was, I don't know if you guys had data on this issue.
I've not heard that.
Statistic that I heard the other day that kind of feeds into that is that if you look at all of the licensed nurses in the state of Nevada today, 40% of them have an out-of-state address, which means that we had a significant number of travelers not licensed to practice in the state of Nevada who potentially aren't working here today or might be working, but probably don't intend on staying because they're just passing through on a traveler's. So it even, I think, exacerbates the fact that we have a significant shortage and it's only going to get worse.
Is that reflective of the number of people who just transferred to Nevada in general, since we're such a, like, an immigrant destination for people? We have so many people coming from California and other states to move here. Has that figure been adjusted?
Yeah, I guess it depends on what their home address is with their license. So there's a lot of them with Nevada license whose home address is still out of state.
And so when you come in to be licensed in Nevada, you sign up for 2 years. You get a 2-year license. So we're still seeing a lot of those COVID nurses still in here. And then some of them, I think, are just renewing their license because you know what a hassle it is to go through, and they might want to come back to travel again through the state. So they're maintaining that. But I don't think it's a ready workforce. And so when we throw out a number, you know, they say that we need 3,000 nurses to meet the national average per capita. I think that number's low. I think we need a lot more nurses to hit the national average. Yes, sir.
I've seen situations as well where we have Nevadans, but they have to take their exams in other states, like in California. In order for them to do that, they have to have an address there. So when they get when they pass their board in California, having that address, I guess when they come back here to get their reciprocity, the address is reflective of where they got their board, where they passed their board. So I've seen many situations that are like that. They say it's a lot easier to take your board exam and pass in California. So maybe that's the reason why.
Well,
the
I know
address
we don't
reflects
have
that.
reciprocity for nurses, so they have to be licensed in the state. So we're trying to get that.
Yeah, I was going to talk about that. It's called the Nurse Licensure Compact. And basically what it is, it's like, you know, we have a compact for driver's licenses in this country. Once you're issued a driver's license in any state, you can go drive in any other state. You don't have to go to the next state and get a license every time you go there. So the same concept applies to this Nurse Licensure Compact, that if you're licensed and you meet the requirements in another compact state, you can automatically come in. Now, 40 states in the country are part of this compact and 2 U.S. territories. Guess who's not? And it's Nevada. And so, you know, that's one of the things we keep pushing for, because I'll tell you when it helps dramatically. If you remember a couple years ago, there was a real increase in RSV cases in hospitals, and it was particularly severe among children. So the problem started in the east and kind of moved west. So when you went out to shop for travelers, by the time it hit us, first, a lot of the respiratory nurses were already taken around the country. And then we wanted to hire them, and they said, well, wait a minute. I can go into a compact state and start tomorrow. If I come to Nevada, I have to wait a few days to get done. I have to file a ton of paperwork, and I have to pay a fee. So which one are you going to go to? You're going to go to the state where you can start working tomorrow.
Well, who is against the pact? I think I can tell you.
Go ahead.
Well, I'll probably get in trouble, but good friends at Culinary and some of the other unions aren't particularly friendly on this issue, are they?
No, they stop it every
I
year.
thought they were God's gift to the world, and all they cared about was people. I won't say more.
Thank you for taking that question for me. Thank you.
Ask and answer.
Yeah.
What are you, going back to workforce development, what are you all doing in regards to getting the high school population, maybe even middle school population, into a pipeline where you have people who are homegrown who are most likely going to stay instead of getting educated and leaving the state, if you can get them into a pipeline? What's going on in that arena?
I think all the hospitals are trying to work with community groups to do that. I'll tell you one very different and out-of-the-box thing we're trying to do, and that is I've met with the folks at Clark County Schools, and we were talking about this, and they said, look, Pat, if you don't get them when they're in middle school, you're going to lose them, because I was focusing on high school students, especially juniors, seniors, and they said, no, that's not it. So, we're racking our brains going, well, how are we going to connect with junior high students? So what we came up with was TikTok. So we created a TikTok channel called Hospital Careers. And what we do is we go out to our hospitals and we film different people and the jobs that they perform. And we're not just doing nurses and doctors, we're doing lab techs, radiation techs, we do food service folks, security guards. There's some just really interesting. So I'm pleased to report that last year we've had over 2 million views on that TikTok channel. So, it was one of those things that I've learned a lot about TikTok, and that is, for the first year, it was like nothing happened. And I'm thinking, we need to pull the plug on this thing. Then all of a sudden, I don't know what happened. I think we hit into the algorithms, and all of a sudden our views just skyrocketed. And I'm expecting that to grow more and more. Now I've got other associations around the country interested, because what we need to do is to tell people about these other jobs. What worries me is when you talk to the average person, they think there are 2 jobs in a hospital, nurse and doctor. They do not realize that there are all sorts of other opportunities. And if you're an underprivileged person who lives in a community where you don't see somebody who works in a hospital, then you might not know those other jobs exist. So that's what we have to get out there. And Jerry and Diego and I have worked on some other crazy ideas that we're still pushing for. But it's really, we're always short on money. But, I think there's some opportunities. But, I think Diego's working on a fantastic project where he's creating these clubs within schools and getting kids interested in it. And when you're part of this club, you can go to a healthcare facility and visit them. And so we're taking the people who are truly interested. But I'm still a believer that we're missing a ton of kids who could connect. I'll tell you, one of our crazy ideas was we were going to do virtual reality where you could go put headset on and walk through a hospital and see the different people and the different jobs that they perform. And not, once again, not the jobs you always hear about, the jobs you don't know about. And just let them experience that. Because to me, even if you weren't interested in a healthcare job, you would put those goggles on to get out of class for a little while and go through and get exposed to it a little bit. So we need money. If anybody has any money, just send it to us.
So Pat, at a macro level, are there even enough people interested in this profession to handle the aging population? Like, are we barking up the wrong tree with this? Like, there just aren't enough people who are interested in this career, there aren't enough training, is it the front end that just will never catch up? And should you be really looking at something totally different like virtual reality, automation, robots, AI, something else? Like, we have to think differently about this? And, you know, any thoughts on that?
Yeah, I'm going to let these guys answer here in a second, but I think that we always have to be thinking of doing things differently.
I think real quick, there's something to be said about augmenting the output of people and being more effective with the work that we have. This is really interesting actually because Senator Hamrick had connected me with Cheyenne High School. He did a survey, and we're doing these surveys in high school. So one of the questions that they asked the students, what is a dream job? In the trades, 6.9%, public safety, 7.9%, athletics, 9.8%, professional, 14%, arts, 18%, and medical was 19.4%. The largest percentage pool of the jobs that the kids in a comprehensive high school want to go in are into healthcare. So the question then becomes, if this were to go across the board in the school district, are we capturing even 15% of the kids that are graduating? Are we showing them career pathways in, or are we just offering some kiosks for them to go apply, right? Like, they need to see the connection, and that was one thing. We did a tour of CSN's respiratory lab, and there's the original club started with 17 kids and grew to 33. And when they went in, when the respiratory therapist said, hey, you know how many physicians I know that became physicians by becoming RTs first? Their eyes lit up. The only path they knew is I need to go get in a tremendous amount of debt to go into medical school. Not that I can actually have steps into a medical career. The lack of pathways and a clear way in is huge. And I think we should look at efficiency, but at the very least, just all the fish that are swimming away that we could just pick up and put in the bucket. There is no concerted effort on this.
Okay, can I add to that?
Oh, yeah, go ahead.
I'll tell you right now, in the medical field and many other industries that I've seen and have talked to a lot of people in the workforce development issue, I mean, I look at agriculture, and while you may not know anybody in agriculture, the fact is that a lot of the kids love it. Why? Because they have hands-on experience. They have 4-H clubs when they're in 3rd grade, 4th grade, 5th grade. What are you guys doing in the medical field to get those kids into, a hands-on experience at that age? How many are you getting into a program? That's what he's tackling. You talk about middle school. That's where it really needs to begin, is middle school. And so, how many of those middle school kids are exposed? Did they know what a phlebotomist is? Have they ever heard the word? Most of them don't even hear it until they get into high school, maybe. You just don't have enough programs. You're not touching enough people early enough in life. You're just not doing it. You have to think outside the box. You cannot go, right now, if I were talking to CCSD all the time, I'd be getting the same stone wall all the time. You got to think around that wall. You got to break through that wall. Mm-hmm. Sorry, that's just my experience from the things that I've seen so far.
Are you aware, are the hospitals, and I don't know this at all, are they doing any sponsoring visas for out-of-the-country nurses and other stuff? Some
yes,
or not?
yeah,
Is
yeah.
that rare, or is it common?
It's probably in the bigger hospitals and bigger systems. It's more common than in the smaller ones because.
So they might. Carla, do you guys do?
She just had to step out.
Okay. So something like HCA and Valley might do some visas.
Yeah, and there's a group that's trying to bring foreign nurses into the state.
There's lots of people.
Yeah, but really interesting what they're doing, and they're making progress. You just keep running into immigration problems. It's just never easy.
I've heard it's very difficult for hospitals to do the visas. Am I correct on that?
Yeah, it's challenging.
Yeah. Okay. That's why I just wondered. 'Cause a couple people asked me about that. I said I don't know. Well, I'm going to a meeting where they probably do.
Yeah. Okay, I want to just give you kind of an overall view of the workforce in the state. So you may not know this, but the federal government designates different areas of the country as health professional shortage areas. And when you look at Nevada, the numbers are very grim. So we have 3.1 million people in the state, and we have, for primary care, 2.2 million Nevadans live in a primary care health professional shortage area. It's worse for mental health. Out of 3.1 million, 2.8 million Nevadans live in a mental health professional shortage area. If you're not in one of those areas, you are among the privileged in this state. And for dental, it's 2.1 million people live in a health professional shortage area. So, we have our work cut out for us. And this is when I go back to say, we've got to get back to the basics. If you want access to care, you've got to have these health professionals in, and you have to pay for them. So, one of the reasons we have a physician shortage is that physicians do not get paid very well by Medicaid, and you have a ton of Medicaid patients who really need access to primary care and other forms of care as well.
The commercial plans pay pretty crappy to the doctors, below
They-
Medicare.
They
Trust
do.
me, I know this as well as anybody in the state. Trust me, they pay that low.
Our commercial rates are very low in this state. So it's
Hospitals do better, but the physicians, particularly the primary care, there's like very few that even pay Medicare. Yeah, and they're all alike, all the insurance companies, and they're no different.
Yeah, so that is a real struggle for the physicians, and that, it doesn't make us a very attractive place to come and practice. We're 45th in the nation for physicians, and at the bottom, 45 at the bottom. Yeah, and so it's not a great situation. But when you look at, do you have any idea what the average medical debt is for a student coming out of medical school now? It's $230,000, but that doesn't include undergrad. So depending on where they went. So when you're sitting there and you're looking at Nevada has very low reimbursement rates, you've got $230,000 in debt. I mean, it's a tough sell. And so the other part of it is everybody wants these doctors to come out and go into private practice. Well, they're not going to do that because you already have this debt. They're not going to go to a bank and borrow a bunch more money to start a practice. And while things like electronic health records are fantastic and I'm very supportive of them, it's killing these private physicians because they don't have a big base to spread those costs. And now with the cyber attacks and different things like that, I mean, the insurance that they have to buy, if they buy it, and they should be buying it, is extremely expensive. So they now tending not to go into private practice and go into larger groups. Yes, sir.
So we made a lot of headroads with the provider tax and moving forward for the inpatient side. Is there something equivalent on the outpatient side that we need to be looking at?
No, I think the state's going to have, I mean, the question is the doctors could do a Medicaid provider tax like the hospitals did. But the problem is in these taxes, there are winners and losers. So even in the hospitals, we have hospitals who pay more in the tax than they get back. We don't call them losers, we call them economically challenged by the policy. And so the thing that has helped us and helped us get this through was what would happen is in a healthcare system, there might be two winners and one losers. Well, the winners were big enough to, from the system standpoint, to offset the loser. And so that helped in being able to get it passed through our group. But with the doctors, it's a very different situation because, who are the losers? The plastic surgeons in general are going to probably be the losers, and they're going to pay a lot in taxes to the whole thing. The primary care doctors are most likely going to be the winners. So, I mean, for us to get 68 hospitals to agree and vote for it, and it wasn't 100% agreement to understand that when it passed. But I can't imagine how the doctors are going to pull that off. Because they're just, until they can break down, the federal government will let you break down the type of doctor, then it could occur. But boy, right now, that's a challenge. But boy, would that solve a lot of problems for everybody. Yes.
Pat, what was the match rate from the feds? Was it 50-50, something higher?
It's something a little higher.
To the 50, slightly over 50.
Yeah.
Yeah.
Yeah. It's a great deal.
Might as well.
And
Doubling your money.
we should be doing that because,
Back to the table as you do every day.
we've got $800 million now coming into the economy, and that's fantastic.
That's net of the tax, after the tax.
That's after the tax, yes.
Nice.
It's net, yeah. Because one of the things I get all wound up with, people say, you guys are going to get over $1 billion, and no, we're not. We had to pay $400 million to get it, so, you got to take that out. Yes.
I think if today the government is promising this is the amount of money that you're going to get if you let us tax you, 5 years from now, you're going to be paying the same tax and they're going to have pulled away all the things they promised they were going to give you and have diverted it to other things because you can't trust the government to continue to abide by the same policy. So for the long-term benefit of people, it's kind of it's a very much a gamble that most people, I think, would be willing to take. On the other side of it, though, for as long as it's a beneficial policy to the state and it gets more net money into the state, would it make sense for the state to pay that additional tax on behalf of the physicians in order to get in twice their money back? Right? If you're arguing that it's, to the benefit of our community and it would benefit everyone, you could have the state put that money up, get twice that back, and it would, be a benefit, and then you can stop doing that the minute that the mathematics change.
I mean, I think it's a benefit to the state to put more money into Medicaid and to raise rates in a couple of areas.
Would the hospitals be in favor of a 2% room tax on the hotels here in order to fund Medicaid?
Oh, I have no idea. That has never come up in a discussion, but it's an interesting thought.
They do that in Florida, I believe.
Oh, okay.
They're big tourist destination, and so they sort of subsidize that. Particularly since so many of the hotels here are now obviously in entities, we're essentially taking money from out of the state and bringing it back into Nevada.
Mhm.
You can put forward the argument that hotels are having their contributions to the federally required contributions to the healthcare of their employees. They're asking Nevada to subsidize that, and it's because the hotels in the entertainment industry, they target people between the ages of 20 and 35. Therefore, they're going to replace them rather than invest in their long-term healthcare. So they'll buy the absolute cheapest healthcare plan they can find. That healthcare plan will delay taking care of the people when they get sick enough to require care. They'll just deny. If 3 months go by, the hotel will fire the person, and now that person's going to end up doing what they're on Medicaid, so they're unemployed, and the state ends up taking up the burden of providing their care anyway. So this is just sort of claw some of that money back.
My only comment would be is that the gaming industry is a very powerful lobby in the state. I think they beat out hospitals. Thank you.
Vermont did this similar kind of thing with a tax on commercial medical claims and used that as a way to fund various programs in the state, and then leverage that money sometimes as much as 9 to 1, depending on what they were trying to fund with that. They funded a health information technology tax, fund. They funded a bunch of primary care medical home things, a bunch of primary care stuff. So they got creative about the way they did that. And because the tax was ubiquitous, it met all the rules for CMS in order to be able to do that. So much the same as you do with hospitals. I wanted to agree, right? Because if only a few do, then it comes back to them that you can't do it that way. But so there's other interesting things we could do. This meaning what you started with this could potentially be leveraged into many other positive things we could do in the state, including help primary care.
Mm-hmm. I mean, we're going to have to do some things to address all these. I do just want to hit on one thing before I go, and I know the time's running out, is I want to just talk about insurance for a minute. And one of the other things that is just a real drawback for physicians and hospitals is that the cost of administrating the practice is unbelievable. The collection process to get money from providers or payers, is just astronomical. So to kind of give you an idea, physicians now spend 15.5 hours a week doing administrative paperwork. I mean, that's unbelievable. We're taking them out basically 2 days a week just doing paperwork. And I think that needs to be examined. When you look at Nevada as a whole in a market, we have 6 government programs, Medicare, Medicaid, Tri-State, all those things. They all have their own set of rules and regulations. As a matter of fact, Medicaid, the director said the other day that in Medicaid, they have 17 different prior authorization forms for that program. That's crazy. And all the others have a bunch of forms. Then you look at it, we have over 20 commercial insurance payers in the state. And each one of those have their own rules and regulations, and sometimes they have subs within their organizations that have their own set of rules. And then you have all the self-employed payers in the state, and they have their own set of rules and regulations. So I don't know how a person could be in private practice today and figure out how to bill for the services they provide. And for hospitals, the cost is just enormous. And I want to just leave you with this thought, and that is, There's a group called the Peterson Foundation, and they looked at the administrative costs per person around the world. And so what do you think the administrative cost per person in the United States is? It's $1,055 a year. Do you know what the next closest is? It's Germany at $306. We are 3 times more expensive. So when you start thinking about where could you save money in the healthcare delivery system, I would suggest to you that administrative costs are a huge area. And I think that's something that we need to focus on. We're actually putting together a little video to explain this to legislators because it's just getting to be overwhelming for all the healthcare providers. And my question always is, what patient benefit does it provide? If it provides a big patient benefit, that's one thing, but if it doesn't, we've got to address it. So I want to thank you all very much for the opportunity. I don't feel like I've been beaten up too badly, so I appreciate that. I'm going to call my wife up and say I'm alive. But thank you all very much. Thank you.
We always have mercy on the first one, Pat, so we look forward to having you back.
You'll never see me again.
Yeah, right. Quick reminder, the Pediatric Round Force is meeting today at 11 a.m. if anyone wants to make that. And just to give you some data, just so people have this, and it was very interesting as I would speak with legislators regarding the workforce data, they'd all ask, very perplexed, where are you getting these numbers? So UNR actually publishes all of this, Dr. Packham's office. If you go to the HEALS website, lasvegasheals.org, and click under HEALS Happenings, you can look at all of the reports that they put out for physicians, for GME. Dr. Packham actually just got 2 new ones that he released, emailed them to us and said, hey, can you guys put this on your site? So we are trying to kind of centralize that data so it's easy for everyone to find. And just for the record outside of the hospitals, so according to, in 2023, it was 3,162 registered nurses that we need to meet the national average. So we got a lot of work to do. Ladies and gentlemen, we are trying to get that work done. Thank you very much for taking the time coming today. We want to be respectful of your time. We're glad you came out and enjoyed the breakfast. Have a great day.